made a clinical diagnosis of a stroke because of acute presentation, hemiplegia, smoking history. Initial assessment was done with NIHSS 9 and yeah, NIHS, sorry about the technical problem. NIHS score was 9, and Labetalol was started to bring his blood pressure in preparation of possible thrombolysis, and we wheeled him as soon as possible for a CT brain, which was normal. And contraindications were excluded for thrombolysis, and written consent was taken, and thrombolysis was done with IV RTPA, and he improves his NIHSS within 2-3 hours to 3, and he was handed over to the medical ward. So that is what we do every day, and this brings us to today's talk, update on early management of acute strokes. I will talk on, it doesn't work again. Slide again.
So slide again, it was
So this will be the outline of my talk: recognition, emergency medical services assessment, in-hospital management, team, emergency evaluation, thrombolysis, and if time permits, a couple of words about thrombectomy. This is how you recognize a stroke. Be fast, which is a niponym for the community actually, to recognize early recognition of a stroke. Balance, some problem in eyes, face, mouth deviation, problems in one side of the arm, and speech issues. If you have those things, all of a sudden, well, think about a stroke and take immediate steps to send the patient to a place where a thrombectomy or thrombolysis could be done. Ischemic stroke, if you see this diagram, if that happens because of a clot in the vessel causing ischemia in the part of the brain, and the center would be a bit of necrotic from the beginning. With the time it gets enlarged. And ischemic penumbra concept, you can see the core is almost dead from the beginning, but the rest of the area, the yellowish area, the penumbra and oligemic area is quite larger. If you relieve the block, you could save this region. So factors that determine the size of the infarct would be extent of the collateral circulation and the time to recanalize. You can see with the time, the area of the necrotic center gets enlarged. Time we say is time is brain, because per stroke you tend to lose about 1.2 billion of neurons. Per hour it will be 120. Per second you're gonna lose about 32,000 neurons. This is why we call time is brain, ladies and gentlemen. If you act fast, you could save some of those. Recanalization is the answer for the stroke. How do you do that? 2 ways, either thrombolysis or mechanical thrombectomy. Well, since we are dealing with the time, you need to have some management protocol from the place you get the stroke, be it home, be it school, be it supermarket, be it hospital, wherever it is. So pre-hospital care is really, really important in this context. So there are so many advanced systems for pre-hospital care, but in Sri Lanka, we have 1990 People are supposed to bring these patients whom they have suspected of having a stroke to a place where thrombolysis is possible or thrombectomy is possible. When they come to hospital, you have to have a stroke team comprising with emergency department, on-call medical team, neurologist, radiologist, everyone should be there. Not only every staff workers, healthcare assistants, as well as the family and patients are also the team members. This is what we are supposed to do in terms of time intervals. Within 10 minutes, they need to be assessed by the multidisciplinary team in the ETU, and within 15 minutes, you call up the stroke team. Less than 20 minutes, you need to wheel them for the CT, and then within 45 minutes, you get all your labs and CTs, everything reported, and within 60 minutes, altiplase has to be administered in a correct case. So initial evaluation by this, we need to, once we suspect a stroke, we need to assess the NIHSS score. That's done by, you need to assess 11 parameters. Scores are 0 to 3 or 0 to 4. If it is 0, there's no stroke. 0 to 4, minor stroke, we say. 5 to 15, moderate. 6 to 20, moderate to severe. And 21 above, it's going to be a severe stroke. So NIHSS helps us to, it's a tool used to objectively quantify the impairment caused by the stroke. And for each item, you either give 0 to 4 score. And the maximum possible score is 42. And it evaluates the severity of the stroke and predicts outcome. Then you need to send them for CT. In our setup, almost all of them would get an uncontrast CT, but in an advanced center, you will follow them up with the CT angiogram or MR angiogram, even with the diffusion scans in an advanced center. But we go by a non-contrast CT brain. And you need to assess the aspect score in this non-contrast CT. That is a radiological criteria for reperfusion. If you have aspect score less than 7, that means fair degree of damage has been already done. So we don't thrombolize those people. If it is more than 7, 10 is the normal score. We go for thrombolysis. And thrombolysis depends on the time, neurological deficit, and radiological criteria. This is what we do. The age has to be more than 18. Less than 80 we have been practicing, but now because with the new trials coming up, the 80 mark we are not practicing anymore. We try to thrombolize people even beyond age of 80. And clinical diagnosis stroke causing measurable neurological deficit has to be there, because we know there are so many stroke mimics playing around. Therefore, it's very, very important to have a clinical diagnosis, and the sufficient time, that is less than 4.5 hours, has to be there for you to consider them for a thrombolysis. These are the couple of, we need to do the CT within 20 minutes, door to needle time 60 minutes. Endovascular treatments can be considered, but they should not delay administering TPA, RTPA, and blood pressure has to be less than 185, 110. And thrombolysis will be done if it is less than 3 hours. Of course, now we go for 4.5 hours. Class 1 recommendations would be people for less than 80 years, without diabetes, previous stroke, NIHSS less than 25, and not on oral anticoagulants, kind of. But class 2 and class 2B indications are there even for people with more than 80 years and people with oral anticoagulants but having INR of less than 1.7. We do practice these indications as well in our setup. Inclusion criteria, onset within 3 years. This is NINS criteria, which was the first trial. They came up with inclusion time window of 3. But we all know because of ECAS, it went up to 4.5. Now we practice 4.5 as the cutoff limit for thrombolysis. This extended period, 3 to 4.5, for patients more than 80 years. I mean, it has been shown in this data, the practice we had within 3 hours can be safely implemented even for 4.5 hours. Even for people more than 80 years, people with on warfarin with INR less than 1.7 and having prior strokes, diabetes, all those people can be safely thrombolized up to 4.5 hours. That's the important message. Mild strokes, if the NIHS score is less than 5, we tend to say it's a stroke is mild. Initially, we were not thrombolizing them, but now if you think the symptom is debilitating, like the patient has lost his speech, then there's an indication for the treating clinician to think on thrombolysis. And this is the effect of RTPA. If you give it for 100 people, 13 have near complete recovery, and 19 will have some recovery at a cost of 6 people getting ICH. Out of those, 3 would be a bit of a severe catastrophic type of ICH. Coming to mechanical thrombectomy, few words. A couple of studies have been done to combine RTPA pharmacological thrombolysis with mechanical thrombectomy. This ESCAPE trial, they have evaluated RTPA versus the standard practice versus standard practice plus mechanical thrombectomy. It came up with the conclusion of among patients with acute ischemic stroke with proximal vessel occlusion, small infarct core, and moderate to good collateral circulation, rapid endovascular treatment improved functional outcome and reduced mortality. So that was one trial. And this is another one, SIFT prime group. They have done the same. It concludes as in patients receiving intravenous TPA for acute ischemic stroke due to occlusions in the proximal anterior intracranial circulation. Thrombectomy with a stent retriever within 6 hours after onset improved functional outcomes. So in developed centers, they go for the pharmacological thrombolysis, and immediately people would get CT angiograms and MR angiogram to see whether they have major vessel occlusion. In that case, they will be followed up with mechanical thrombectomy. These are the indications for a patient should receive mechanical thrombectomy with stent retriever if they meet all following criteria. That is pre-stroke MRS score of 0 to 1, MRS modified Rankin score. 0 means almost always you are normal, no problem at all. 1 is, again, you are able to get your day-to-day activities. And causative occlusion of ICA, intercarotid artery or middle cerebral artery. Age has to be more than 18 years. NIHS, there has to be deficit of more than 6. And aspect score, again, has to be more than 6. And treatment can be initiated within 6 hours of symptom onset. So those are the criteria for mechanical thrombectomy. Coming into general supportive care, we need to avoid hypotension and hypovolemia. That's really, really important, not only in stroke, in any disease. And blood pressure has to be kept less than 185, 110. You can use IV labetalol for this purpose. And blood sugar, as in any other critical illness, has to be kept around 140, 180. And before you give altiplase, it's always better to exclude hypoglycemia as a cause of this presentation. So blood sugar should be more than 50. And post-TPA, you need to watch them for ICH. You need to keep them in NIHS start hourly for longer hours. See whether there's any difference to NIHS score. If it is going up by 2 points than the baseline, you need to suspect whether there's ICH and get them immediately for a CT. And in case of ICH, you need to take corrective treatment. And you need to see for angioedema. Having said that, I have never seen a patient with angioedema in ETU. And blood pressure, as he told, has to be kept less than 185, 110 over 24 hours. And optimal supportive care, hydration, nutrition, and things has to be there, including explanation and other supportive care. And then you need to safely hand over these patients to medical team for further evaluation and further escalation of antiplatelets and other treatment. So that ends my talk. I hope I have finished it during the time. And I would like to thank World Medical Association, KJ, and all of you for your kind listening. Thank you very much.
Thank you very much, Dr. Sena Ratna, for an excellent talk and staying on time. Let me introduce our second speaker, Dr. Damit Liyanage, consultant neurologist, teaching hospital Karapitiya. I invite Dr. Liyanage to present his talk on evaluation of a young stroke. Over to you, Liyanage.
Thank you, Dr. Asha, and good afternoon for everyone. At the outset, I would like to thank Gall Medical Association for inviting me to present in this forum. For the next 15-20 minutes, I'll be concentrating on evaluation of a patient with young stroke. Mainly, it will be about the evaluation of a patient with young patient with an ischemic stroke. And it will be a kind of a continuation of Dr. Ganaka's presentation. So we have a patient, 37 years old patient coming with the clinical features of a stroke. So initially, he was managed with either thrombolysis or in suitable patients with suitable facilities available, he might go ahead with thrombectomy. So after that, after the acute evaluation is over or acute condition is settled, how would you proceed? So stroke is considered to be a disease of the elderly. As you can see, with the age, the stroke occurrence or the prevalence rises very rapidly. However, for the last 30-40 years, there had been interest in patients, young patients coming with stroke. And there had been a rising trend of people, young people coming with stroke. That has been observed since 80s. So what could be the reasons? One obvious reason could be increased awareness of stroke, increase early detection of stroke, and we are doing more and more MRIs, which would pick up previously undetected strokes. So that could be one reason. And the other main important factor could be increasing prevalence of vascular risk factors, or the conventional or modified cardiovascular risk factors among young population. Then young people, especially females, have specific risk factors for stroke, such as pregnancy, puberty, and oral contraceptive use. Then behavioral risk factors, increasing trend of behavioral risk factors for stroke, such as low physical activity, obesity, excess alcohol, smoking, and illicit drug consumption. All of these things could have contributed to the observed rising trend of young people presenting with stroke. So what is the definition of a young stroke? You can have your own definitions for a young person, depending on your beliefs. But when it comes for a patient with a stroke, at what age you would consider that patient to be a young patient? Well, unfortunately, there's no uniform or concrete criteria to define a young stroke or a stroke in a young person. In medical literature, there has been wide variation among the cutoff point. It has been varying from 35 years to 65 years. Certain literature, they consider the low age, even as 35 as a young stroke. For some authors, some literature, it considered age around 60-65. But in most recent literature, it is considered either 50 or 55. A patient with age of below 50 or 55 to be a patient who warrants investigations apart from the routine investigation. So how would you evaluate a young patient coming with the ischemic stroke? we can divide it into two parts: urgent evaluation and the subsequent evaluation aiming at finding an etiology. I won't go into details about the urgent evaluation because Dr. Senar had an excellent account on the urgent evaluation and the management. We have to consider the differential diagnosis, then brain imaging. In some patients, vessel imaging might be needed, then triage for hyperacute reperfusion therapies, then certain laboratory studies might be necessary. So coming for the subsequent evaluation, which is aimed at evaluation for the etiology. We can divide it into broadly two categories because certain investigations, almost all the patients, they might be necessary. Other investigations, only selected patients might benefit from those investigations. However, there can be overlap between these two groups, and the basis of stroke evaluation or the subsequent evaluation is it should be tailored to the patient, depending on the patient's history and the other clinical features, and the probably with the results of the subsequent investigations, we should decide on further investigations. So it should be tailored to the patient, because there are around more than 100 cases, 100 causes for strokes in a young patient. But we can't be evaluating all of evaluate for all the causes in every patient. So it should be tailored. We can broadly categorize the etiology of young stroke. The problem might be in the heart, cardioembolic stroke. It can be structural heart disease or a rhythm abnormality. Then there can be abnormalities in blood vessel wall. They can be inflammatory abnormalities or related to infections, or sometimes non-inflammatory vasculopathies could also be there. Then there can be problem with the blood itself. Blood might be more hypercoagulable. Then certain genetic causes might be there, which would predispose for strokes. However, there can be overlap between these groups also. So all starts with history. So after reperfusion therapy and after the patient is stabilized, we might have to go back again, because during the early or immediate evaluation, we might not be able to take a good a detailed account from the patient. So common things first. So we have to inquire about conventional or modifiable cardiovascular risk factors such as diabetes, hypertension, and all that. Because you might be surprised to see the rising trend of cardiovascular risk factors among young people. So we have to look into that, whether the patient has past history. Then whether there are symptoms or past history suggestive of vasculitis, autoimmune disorders, or connective tissue disorders such as SLE, systemic sclerosis, Sjogren, and all that. We have to ask about arthritis, skin rashes, any renal diseases, and all that. Then we have to ask about cardiac disorders, whether the patient has been diagnosed to have any rhythm abnormalities, structural heart disorders, and including whether the patient had been diagnosed to have a patent foramen ovale, because recent literature suggests that there can be a relationship or association with stroke with the PFO. Then any recent neck trauma, which would predispose for carotid dissection. Then recent or chronic infections. Increasingly, we have been getting reports about association between stroke and infections. Certain infections can cause, can cause a stroke, such as TB, meningitis, infective endocarditis, like that, or syphilis, HIV. And certain infections, they can be just a risk factor. There had been reports of recent respiratory tract infections or even gastrointestinal infections might act as a risk factor for stroke. Then we have to inquire about oral and genital ulcers. Especially, there are many causes for oral and genital ulcers, which might be the same etiology might be associated with stroke. Then we have to ask whether the patient has a history of epilepsy, seizures, or there had been a seizure with the onset of the stroke. Then migraine with aura. Now it is recognized that migraine with aura is a risk factor for stroke. That association is not strong for migraine without aura, but definitely for migraine with aura, it is now considered a risk factor, and the risk increases or it adds up with other risk factors such as smoking, oral contraceptive use. Then malignancies, especially hematological malignancies, head and neck malignancies that can cause stroke by various mechanisms. Then use of alcohol, especially binge drinking, then illicit drug use, especially cannabis, cocaine, amphetamines. All of these can predispose to stroke. Then family history, because there are certain genetic causes where the patient and the family members might be predisposed to stroke. Coming to the examination, temperature, because if a patient with a stroke has a temperature, that changes all the evaluation. Then we might especially look for an associated infection, which might be related to the etiology. Then whether the patient is pale or plethoric. Then whether there are any dysmorphisms, hyperextensibility, for example, whether there are features of Marfan syndrome, Ehlers-Danlos syndrome, then Horner syndrome, very important, that might indicate a underlying carotid dissection. Then stigmata of infective endocarditis, stigmata of connective tissue disorders or vasculitis such as vascularity crash, arthritis, alopecia, all that. Then cardiovascular examination, including rhythm and for examination for carotid growths. Then again, we have to examine not only the history, we have to examine for oral and genital ulcers as well. Investigations, certain investigations we should do in almost all the patients. ECG is a must, and a transthoracic echo. I think these should be done in every patient. And in some patients, transesophageal echocardiography or cardiac CT or MRI might be necessary, especially if the transthoracic echo is non-diagnostic or if there's a high index of suspicion for a cardioembolic source for the stroke. Then prolonged ECG or Holter monitoring. It might be necessary in selected patients if the preliminary workup is negative, especially if you are suspecting an embolic stroke with undetermined source. That means that especially the radiology is suggestive of embolic stroke, especially if there is a large vessel occlusion sometimes or multiple infarcts in a single vessel territory. These might indicate the etiology or the source might be cardioembolic. So probably in these patients, especially young patients, they might need a Holter to look for any paroxysmal atrial fibrillation or rhythm abnormalities. Then after, apart from the cardiac evaluation, we should look at the blood vessels, or vessel or arteriopathy evaluation. Magnetic resonance angiography or MRA of neck and head would be sufficient for most of the patients. In selected patients, you might be able, you have to do you have to extend the study up to the aortic arch if you are suspecting something, some problem in the aortic arch region. If MRI is not available, CT angiogram might substitute depending on the availability. Digital subtraction angiography, which is considered the gold standard for evaluation of blood vessels or the vasculature, is usually reserved for cases when the diagnosis is uncertain after the MRA or CT angiography, or it is inconclusive. Then how about the MRI brain? it can give more details about the stroke than the CT. However, in young patients, sometimes we might not be able to do it for each and every one. However, that would help us to exclude the stroke mimics, especially if the history is atypical. And if you are suspecting some inflammation, vasculitis, or CNS infection, then probably we might go ahead with, we should go ahead with that. Then sometimes we can combine the MRI brain with the arterial wall imaging, which is called black blood sequence. Usually for that, we need a high resolution MRI, at least 3 Tesla. And usually in that, they suppress the signal from the blood and the CSF. So the radiologist can see the blood vessel wall in detail. So that might help to detect non-stenotic lesions, which are not apparent on angiography using MRI or CTA. And it can further characterize stenotic lesions as well. This is carotid dissection. One common cause of stroke in young people, especially in developed countries. It can be traumatic or spontaneous, and the spontaneous one are usually can be associated with connective tissue disorders such as Marfan and Ehlers-Danlos loss. Then we might pick up arteriopathies in vessel wall imaging. Usually it's defined as imaging appearance of an in situ arterial abnormality, such as stenosis, irregularity, occlusion, banding, or pseudoaneurysm, or dissection flap, and not attributable to an exogenous thrombus, and not considered a normal developmental variant. Arteriopathy, which is characterized by progressive stenosis of the internal carotid arteries and formation of collateral vessels that gives a puff of smoke appearance in the angiography, such as this in this angiography. Then another interesting cause is fibromuscular dysplasia, which affects medium-sized arteries, predominantly in young females of childbearing age. You can see multiple stenotic lesions, especially in the proximal vessels, followed by dilated or aneurysmal appearance. Then there's another condition, especially common in in children, which is called focal cerebral arteriopathy. It's a angiographic diagnosis, mainly unifocal and unilateral stenosis or irregularity in one or large intracranial arteries of the anterior circulation. Usually it's thought to be an inflammatory process, either infectious or post-infectious, and it's predominantly in children, and there are two subtypes, dissection or inflammatory. Then hypercoagulability screening. I think antiphospholipid syndrome screening we should do in all patients, young patients coming with a stroke. Lupus anticoagulant, anti-coagulopin antibodies, and anti-beta-2 glycoprotein. And if they are positive, we have to repeat it in 3 months. Then genetic thrombophilia screening, such as protein C, S, antithrombin deficiency, all that. In algorithms and textbooks, they say we have to do it, but I have reservations with especially in setup, resource poor setup like in our country, whether we should go ahead with all of these things in every young patient, because the association is not that strong for arterial occlusion. It's mainly with the venous thrombosis. There is an association, but it's not that strong. So it might not be necessary in each and every patient. Then homocysteine levels, well, if you can do it, that's fine. Then other routine investigations, especially to exclude other modifiable cardiovascular risk factors, and the inflammatory markers and the clotting profile. Blood picture, especially, we should concentrate on whether there are features of anemia, sickle cell disease, or polycythemia. Then in selected patients, we might have to go ahead with further extended testing, ANA, anti-neutrophil cytoplasmic antibodies, and in certain patients, we might have to do DSA and CSF analysis to exclude inflammatory causes. Then, as I said, in certain patients, we might have to exclude the underlying infection, especially HIV, syphilis, TB, and fungal, and melioidosis, especially in this part of the world, then viral infections. And in a minority of patients, we might have to go for genetic testing. There are genetic and biochemical causes of rare causes for stroke, such as Fabry's, mitochondrial, then CADASIL and CADASIL, Carney syndrome. There are many other syndromes which has a genetic and biochemical etiology. They might also predispose to stroke. So that concludes my presentation. That's, I think, a basic outline for evaluation of a young patient with the ischemic stroke. Thank you.
Thank you very much, Dr. Damit Liyanage, for the very comprehensive talk on evaluation of a young stroke. Let me introduce our third speaker for the session, Dr. Nishantha Gunasekara, consultant neurosurgeon, teaching hospital Karapitiya, to deliver his speech on evaluation, the management of a hemorrhagic stroke. Over to you, Dr. Gunasekara.
Thank you very much, Varsha. At the onset, I'd like to say that I'm extremely honored to be a thorn in the garden of all these physicians and would-be physicians, only the surgical thorn. Also to my good friend Krishanta Jayasekara for inviting me to give this talk on management of intracerebral hemorrhage. Hemorrhagic stroke, we surgeons call it ICH for short, but let me be specific about the terms that we use first. Intracerebral hemorrhages, I would like to convert that to another nomenclature, intraparenchymal hemorrhages. Because when I was given the case scenario, it was a 47-year-old gentleman who was in the gym exercising and who suddenly had a loss of consciousness and was found in the bathroom with a at a level of consciousness and found to have hypertension. Blood pressure was 220 by 115. So I was wondering, in my work to do a presentation, all the learnings that we have done all over the world, the Stitch trial, the different trials, intraparenchymal hemorrhage is controversial. Management of intraparenchymal hemorrhage from a surgical point of view is at best controversial. Therefore, if I were to put a presentation, I would have been discussing controversies. I would have been discussing, okay, what is the surgical management of this particular degree of intracerebral hemorrhage, and what is the percentage of surgical management for this percentage of the size of the intracerebral hemorrhage. Therefore, I thought, in all justice, I would like to present this as a management of intraparenchymal hemorrhage, where the controversies lie, where there are no controversies, and when it is absolutely straightforward surgery. So let me start by saying management of intraparenchymal hemorrhages depends on absolutely an individualistic approach. That is the problem. The problem of managing intracerebral hemorrhage is that it changes from one person to the next. There are certain things that you need to do, like evaluation of the causes, the etiology. I'm not going into details about the etiology, hypertension, cerebral angiopathies, cocaine abuse, alcohol. You can get the list of causes of etiology of intracerebral intraparenchymal hemorrhages. But when a person presents to you with an intraparenchymal hemorrhage, it is up to the physician to understand what is going to happen. Therefore, I'm going to give you the philosophy of surgical intervention. The philosophy of management of a hemorrhagic stroke is to make sure the damage is minimalized. What is the damage? The damage from the blood in the intraparenchymal component, because blood is toxic. That is the primary problem of intracerebral hemorrhages or intraparenchymal hemorrhage. Blood is toxic, and the blood has caused edema, and there is a raised intracranial pressure. So as neurosurgeons, we want to protect the brain parenchyma, the normal brain parenchyma, and we want to bring the pressure down. Otherwise, the final common pathway is further ischemic damage to the brain and possible herniation and coning and death. So judging by the referrals that we get, the true controversial nature of management of intracerebral hemorrhage is extremely evident, because all of us struggle to understand, okay, is the volume, you can get the volume by radiological assessment, or a way of, you can ask the radiologist to give the volume of the ICH. If it is 10 cc, what are you going to do? If it is 20 cc, what are you going to do? If it is more than 30 cc, what are you going to do? So clinical assessment comes into its own when it comes to management of intracerebral hemorrhages. What are the clinical assessments? Age. Now people say if the age is middle age, or if the age is, you talked about how you define age these days, middle age maybe from 40 to 60. Even if the age is, if the patients are young, if there is clinical deterioration, it is justified to evacuate the ICH. What is the comorbid conditions of the patient? Whether the patient is going to withstand major surgery, whether the patient has anticoagulants on board. Sometimes there is dual antiplatelets, there is warfarin, there is underlying medical problems. So evaluate the medical, truly individualistic. So if you go away with the idea that management of hemorrhagic strokes is truly individualistic and truly multidisciplinary, that is the message that I want to give it. If you study, if you do a meta-analysis, there are meta-analysis that have been done, especially the Stitch study. They say, okay, management, surgical management vis-a-vis evacuation of the ICH with a craniotomy. If you study equal patients, conservative management also comes, there is no difference, right? But individually, one patient who has a large ICH, who has got features of coning, then those patients have to be surgically managed. How do we manage surgically? What are the criteria that we follow to make sure the patient has a safe surgical outcome? The most important thing is evaluating the patient's Glasgow Coma Score. So the Glasgow Coma Score is a snapshot. You take the snapshot. If the patient presents with a intracerebral hemorrhage, which is 10 cc in volume, Glasgow Coma Score is 11, you evaluate. You keep the patient in a medical ward, or you can refer to a neurosurgical ward. We evaluate what is the Glasgow Coma Score in 24 hours, or when you observe, has it dropped? If it drops by 2, you are justified in doing a CT scan. And if the volume has improved, if the volume has enlarged, and the GCS has dropped, commensurate with the clinical picture, we opt for surgery. This is the true picture. Sometimes we take over to the neurosurgical wards to make sure that the patient doesn't deteriorate undetected. But if the patient deteriorates rapidly, then you're justified in asking for a surgical intervention. Observation of Glasgow Coma Score. Then observation of the neurological deficit. Further neurological deficit. The patient may come with upper limb weakness. Patient may progress to a lower limb weakness. Patient may deteriorate GCS rapidly. Then that is the time that you say no argument about it. Refer to the neurosurgical unit to make sure the patient has a safe outcome. Amount of is the patient suitable for surgery? Is the patient on anticoagulants? Now sometimes we prepare the patient in the night when you refer to the neurosurgical unit. When we assess, the patient is on warfarin, INR is 3.5. Even if the patient deteriorates, if those conditions are not suitable, then we cannot operate. We just cannot operate because the surgical intervention, the cure is going to be more devastating than the natural progress of the disease. So in managing deteriorating patients, we've got to make sure we've made the full evaluation of the patient, optimize the patient, and then we take for surgery. Surgical, before we do that, sometimes most of the patients have hypertension on admission. And so much so that they think that hypertension is the cause for this ICH. Hypertension is detected when the patient, when you reach middle age and when you reach advanced age. Therefore, just because there is hypertension at presentation, that doesn't mean hypertension is the cause. Hypertension may be the result of the ICH. So the ICH has to be evaluated in a separate way. Maybe the patient has a myocardic aneurysm or a microangiopathic vasculopathy, or the patient has hypertension. In fact, they have now discussed hypocholesterolemia, low cholesterol, as a cause of ICH. So if you are treating a patient with hypercholesterolemia, the cholesterol is very low, then that itself is a risk of having an intracerebral hemorrhage. So therefore, don't attribute hypertension per se to hemorrhagic stroke. So what do we do? What is the philosophy of surgery? The philosophy of surgery, as I said, safe craniotomy. Craniotomy is not a simple procedure. Sometimes the cranium, we have had patients we've been operating, patients might pass away on the table because we cannot stop bleeding if the patient on multiple anticoagulants or warfarin. Therefore, make sure the patient is optimized. These can be done in the medical ward. All over the world, that is what happens. Either in a stroke unit or in a medical ward, you optimize the patient, optimize the parameters. You may be able to give mannitol, you may be able to give dexamethasone, some diuretic to get the blood pressure down. That is the Cushing reflex that is going on. Control that temporarily and inform the surgical unit that this patient is going to benefit from surgery. So that can be evaluated by everybody. Our part, surgical management of hemorrhagic stroke is, as I said, to prevent coning primarily, prevent central herniation, and prevent the blood, which is toxic to the rest of the brain. You talked about the ischemic penumbra, from progressing. So what we will do is we do a craniotomy. Most of the time it's a craniotomy. A limited craniotomy to assess the intracerebral hemorrhage, evacuate the clot, and try and stop the bleeding. Most of the time, we do not see a vessel that is bleeding. They talk about the Charcot-Bouchard artery of cerebral hemorrhage from the middle cerebral artery. Rarely we find a spurting blood vessel inside the cavity, so we can coagulate that. Most of the time, what we find is it is just oozing. It is just general ooze. You remove the clot, and you find oozing all over the cavity. So we stop the bleeding by using bipolar diathermy, or we can use surgical cellulose to stop the oozing. Most of the time that surgery is indicated for the above reasons of raised intracranial pressure and trying to prevent the damage surrounding the damage. Also, what we discuss is how easy is it to access the clot. If it is within 1 centimeter to 1 to 2 centimeters on the surface, it's an easy accessible clot. But if it is in the capsule, it is deep. The damage that you cause in trying to reach the capsule hemorrhage is rather large. So do not prefer small hemorrhages. Small hemorrhages have no indication for surgical evacuation, unless, as I said earlier, there is progressive neurology or the ICH becomes big. So small ICHs, how do we evaluate? What do you mean by small? If you want a cutoff point, it is 30 cc, 30 ml. You can get the radiologist to assess it, the height, length, and the depth of the ICH. You can calculate it, multiply those three values, and you get a number. So 30 cc or more, you are justified in making a request for surgical evaluation, provided the previous parameters and the stability of the patient is established. All right. Depending on where the lesion is, we see very regularly the capsule hemorrhages, surface hemorrhages, cerebellar hemorrhages, brainstem hemorrhages, thalamic hemorrhages. Those are and temporal lobe hemorrhages. Those are the general areas that we find ICH from the referrals that we get. There are certain instances when the thalamic ICH, the thalamic intracerebral hemorrhage, ruptures into the ventricle, which is a good problem from a neurosurgical point of view. So we can get away with a single burr hole and evacuating it via an EVD. If there is intraventricular blood following intraparenchymal hemorrhage, that is a surgical indication for evacuation. Because we don't need to do the major operation of doing a craniotomy. We can put a burr hole, insert an external ventricular drain into the ventricle, and the blood clot will come out. The thalamic blood has ruptured into the ventricle. Therefore, that's a good pathway to take the blood out from the ventricle. If it is a posterior fossa hemorrhage, that is very, very significant. Posterior fossa hemorrhages can kill because, as we all know, anatomically, the posterior fossa is very close to the tonsil. Obviously, it's in the tonsil is in the posterior fossa. So if the cerebellum has an ICH, it is most likely that we will do certain interventions to prevent the patient's tonsils from herniating. What we do usually is, we've done many times, put an EVD and take the pressure out. Very rarely we would go in and do a posterior fossa craniectomy and remove the blood clot from the posterior fossa as well. One important fact is, in trying to evacuate an ICH, we need to make sure that there is no underlying sinister pathology. A young stroke, a person who has other diseases like malignancies may harbor a tumor inside, or an AV malformation, or an aneurysm. In fact, if I always tell my students and my registrars and my senior registrars, if it is in an unusual location, very, very important. Capsule is the usual suspect. Capsule is a Charcot-Bouchard artery of cerebral hemorrhage. Capsule hemorrhages we have all seen. Thalamic hemorrhages we have all seen. Brainstem hemorrhages we have all seen. Make sure if it is on the surface, if it is on the frontal lobes, if it is on the temporal lobe, if it is on the cerebellum. Those are the suspicious areas when it can harbor something more sinister, either a microaneurysm or an AV malformation. If it's an AV malformation, if you go in unprepared in the night, you get a registrar or a senior SHO to do it, he's going to call us, I cannot stop the bleeding. So if you have a suspicion that it is on the norm, it's not in the normal areas, please make sure that you evaluate with a CT angiogram, ideally a DSA, and then we are happy it's just a hemorrhage for other reasons such as hypertension or vasculopathy. Tumors do not, there is no point in doing an MRI scan to evaluate a tumor at the time of the ICH because the image is completely distorted. It will hide the tumor. So let it settle down, manage conservatively, do the MRI scan later, and then refer back. That is the practice around the world. You evaluate in an unusual situation, in an unusual place. If it's in an unusual place in the brain, evaluate. Do not just go in and try to evacuate a clot. One more, probably the final and the most important point is subarachnoid hemorrhage associated with intracerebral hemorrhage. If there is blood in the subarachnoid space, make sure there is no berry-aneurysm. We have had instances, we evacuate the ICH and there's an aneurysm. You cannot clip an aneurysm during an emergency operation. In the night, you just cannot. We don't have the facilities. It'll bleed out to death. You put a clip and end up with a stroke. So subarachnoid hemorrhage associated with an ICH is a red flag. Make sure you have evaluated it with at least a CT angiogram before we refer on. Last point, decompressive craniectomies. Where does decompressive craniectomies, what is the place for the decompressive craniectomies in ICHs? There is a place if the patient is moribund, if the patient is deteriorating, we do what is called a decompressive craniectomy to make sure that we bought some time before the patient herniates and dies. But just doing a decompressive craniectomy is inadequate for the first reason I said. It doesn't do anything to the damage caused by the ICH. The ICH itself causes damage, so we need to evacuate the ICH and do the decompressive craniectomy. Finally, I would say that surgical evacuation of an ICH as an emergency is a very, very sensible and reasonable procedure, provided the patient's preoperative workup has been done within the limited time. But it's in an ideal scenario, it's done on a routine case that we can evacuate it under the microscope, and we can do a better job during a routine planned operation. So evaluate the patients and refer on. That's the modern practice. Case-based, individualized attention to every single ICH. That is the reason that one cover-all presentation will not cover it. It's a truly discussable and a contentious issue. Thank you for the time.
Thank you very much, Dr. Gunasekar, for an excellent presentation on the management and evaluation of intraparenchymal hemorrhage. So we have managed the acute ischemic stroke, the acute setup in the ETU by a consultant physician, and interparenchymal hemorrhage by consultant neurosurgeon. And we are on the way to investigate our young patient to find out the etiology for the young stroke. Now we have come to the final stage and the most important stage of the management of stroke rehabilitation. So let me introduce our final speaker, Dr. Callum Deshapriya, consultant rheumatologist, teaching hospital Karapidia. He will enlighten us on the stroke rehabilitation. Over to you, sir.
Thank you. Good afternoon, everybody. I would like to thank Dr. Krishanta Jayasekara, the President, and the GMA for inviting me for this workshop teaching capsule to talk to you about stroke rehabilitation. What I will be basically doing is some introduction to stroke rehabilitation, and I will discuss some few important practical aspects. I will not be able to cover the stroke rehabilitation at length, but it is basically a introduction and some important practical issues. So we have listened to these two case scenarios, how to evaluate and what is the initial management of these two patients now. Right. Now, this is a patient with a proven or person with suspected stroke, and immediately you heard all these brain imaging and you make a diagnosis. There are two possible diagnoses basically, whether it's a hemorrhagic stroke or a ischemic stroke. So we heard briefly about the initial management in the ETU and maybe early in the medical unit. Management in a specialized stroke unit would have been the ideal place to manage these patients even in the acute setting. If you have a acute stroke unit, that is the ideal place. So for that matter, and I suppose what is the care given to these patients initially at the ETU and in the medical units in this initial state in our setup equals to managing the patient in a specialized stroke unit. I hope if the facility is available and if it is run by a specialized multidisciplinary stroke care team would have been the idea. So what is the management sort of supposed to be in a specialized stroke unit? So you have to make some assessment initially. After the initial stabilization, the patient transferred to the acute stroke unit. Assess the swallowing function, hydration, oral nutrition, optimal positioning, and early mobilization. And I am I am stressing these features. Now, these patients practically in teaching hospital Karapiti will happen in the medical unit. After transferring this patient from the ETU, I don't think that they will be retaining for more than 24 to 48 hours. They will be transferred to medical unit. So this actually should be happening in our setup in the medical unit. So it very important, you have to pay attention on these aspects. So the patient would have been started before coming to the rehabilitation hospital or the post-acute rehabilitation. Before coming to that unit, patient should be on statin, decompressive hemicraniectomy or some other surgery if indicated, managing carotid stenosis, managing deep vein thrombosis, pulmonary embolism, all these possible complications. And also patient would have been evaluated to prevent and further occlusive vascular disease. Now the patient is now presenting with occlusive cerebral vascular disease. And it is paramount important to make sure that the patient will not get a second or subsequent similar attack. So all these things should be in place before the patient transferred to proper rehabilitation care. So in the other hand, the rehabilitation, what we call rehabilitation, should be started right from the beginning. Maybe in the acute setting in the ETU and also in the medical unit or acute stroke care unit. So that is the place where you will be considering the rehabilitation. It is very important that you don't delay rehabilitation. So what is the type of rehabilitation in these places we'll discuss? You don't wait till the patient goes to the rehabilitation unit to start rehabilitation. What is the post-acute stroke rehabilitation care? So two options available. So you have initially stabilized the patient and have taken all the measures and you have evaluated the possibility of the risks for the subsequent attack. You have taken measures to prevent them and now ready to send the patient from the acute setting two places. Patient will be discharged from the hospital and will go home, or are we going to transfer the patient to the rehabilitation unit? The researchers available and the evidence available up to now says the best place the patient can go or should go is not home, but to the rehabilitation unit. And as far as the long-term outcome is concerned, and that is the best place. So you can send the patient home and 1 hour per day, 3 days per week, one single therapist if possible, and you can do you can do some rehabilitation at home, but the best is in the rehabilitation hospital, right? So when you refer the patient to the rehabilitation unit, there are certain inclusion criteria and exclusion criteria. It is not all the patient that will be accommodated in the rehabilitation unit. But what are the inclusion criteria? But it is everybody agrees that all acute or recent acute stroke patient should be managed in the rehabilitation hospital. So that is the requirement. So that is not possible all the time. Some patients greater than 1 year, so this is less than 1 year, all the patients, you should consider rehabilitating in a stroke unit. Earlier the better. Immediately after acute care, the patient should go to the rehabilitation unit. But for some reason, the patient will go home, but still you can take them in within 1 year. If it is more than 1 year, still there is a provision. Under certain situations, you might consider even after 1 year. In our setup, where the beds are very limited, rehabilitation beds are not available freely, not very many stroke unit or stroke rehabilitation units available in our country. For that matter, dedicated rehabilitation units available in our country, we have only 5. Melbourne Rehabilitation Hospital is 1. There are 4 other units, dedicated rehabilitation units in the country. So, I mean, beds are very rare. So, we have to fight for the beds. And so, we have very strict criteria when we consider taking a patient into the rehabilitation hospital. It is not only stroke patients, there are so many other conditions that we have to take in. Patients should be medically stable. That you have to Confirmed diagnosis of stroke has been identified. All medical issues of comorbidities have been addressed. At the time of discharge from acute care, acute disease process and no impairments are not precluding or preventing participation in the rehabilitation program. So if you have a patient, even if the patient is stable but aggressive, and will not be a suitable person for rehabilitation in a dedicated stroke unit or in the rehabilitation unit, that will disturb all the other rehabilitation work that is happening in the rehabilitation unit. So we are very selective in taking patients. The follow-up plan is in place at the time of referral. So don't refer patients without a proper follow-up plan from your end. What is your subsequent follow-up plan for this particular patient? Patient demonstrate at least a minimum level of function. Patient has the stamina to participate in the program, demands, schedules. The patient is able to follow at minimum one-step commands. So in a dedicated rehabilitation unit, when the beds are in limited numbers, so we have to select patients. So there is no point in taking a patient. Two-way communication is not possible. So therapist should be able to give commands and patient should be able to understand the command and carry out these commands. If that situation is not happening in a limited space, and we have to select patient. The patient has sufficient attention, short-term memory and insight to progress through rehabilitation process. Patient demonstrate by their post-stroke progress. Now this is when a patient is referred after 1 year or so. So there are situations where you might consider taking these patients into rehabilitation program. So after assessing the post-stroke progress and the potential to return to pre-morbid or baseline functioning. So if there is no potential that the patient will improve on what is having at the moment, there is no point taking that patient in. So for that, you need a very careful assessment before taking the patient in. There are no behavioral issues limiting the patient's ability to participate. So there are some exclusion criteria as well. Severe cognitive impairment, preventing the patient from learning and participating in therapy program. Behavior is inappropriate, putting the self and others at risk. Terminal illness with expected short survival, and for a dedicated unit for a long period of rehabilitation, this is probably not the type of patient. Not willing to participate in the program. You cannot take the patient into the rehabilitation unit by force, not because the parents or the family members want. The patient's willingness should be there. So there are some other the exclusion criteria, so institutional specific criteria. Each institution has their own criteria. In our setup, one of the important criteria I must tell you is, so we cannot take, because our supportive staff in the Melbourne rehabilitation unit is very less. And we always ask, don't refer the patient, or we will not take for patient if there is no caregiver with the patient. So that is a very limiting factor. So very unfortunate in our setup. If we have a good staff in the Melbourne rehabilitation unit, we could have taken these patients in and do a better job. But we have to rely on the caregiver because we are short supply. We are in short supply of this, the health workers. So if the caregiver happen to be a breadwinner in the family, so that patient will definitely go home. That is happening and very unfortunate. We have no answer for that. So at the time of arrival to the rehabilitation unit, there will be very detailed screening and assessment. So all this will be done. What is stroke rehabilitation? It's a progressive dynamic, and we set goals, and we are trying to achieve these goals during this process, aimed at enabling the person with impairment. They are coming with impairment. Aim is to enable them and reach their optimal physical, cognitive, emotional, communicative, social, and functional level. So that is the definition, sort of the definition of rehabilitation. So I will basically just discuss about, especially for the benefit of trainees, medical trainees, some introduction to medical rehabilitation. This is the functional model of the WHO functional model of rehabilitation. We talk about human body in three ways. So the human body functions as physiological and anatomical functions, and we do activities, and we do participate in life events. So these are the three basic things any human being will do. Right now, this is what happens when the patient has a health condition. So there will be some abnormalities of the dysfunction in the physiology and anatomy, impairment. And as a result of this, the patient will not be able to carry out activities. And as a whole, the patient will not be in a position to participate in life activities in the community, in the society. What he was doing, he will not be able to do. So what is rehabilitation? To address all these issues is the process of rehabilitation. So we'll take these two patients, stroke, will apply to this model and see what it really means. What is the health condition? Is the stroke. What is the body function impairment? The cerebral infarction, right hemiplegia, visual, swallowing, speech, bladder, bowel. So like that, these are the impairments. So we have to address these issues. So initially, ideally in the acute stroke unit. What are the activity limitations that we talk about? The patient will not be able to do at least the basic minimum activities of daily living and all the other activities that we do. And so we will have activity limitations. And what is the participation restrictions that we talk about? Cannot continue with his occupation. So in this short case scenarios, there are a lot of other things that we need to know. It is not only the medical part. There are so many other things that we have to extract from the patient in that history. But there are so many other aspects that we have to explore. And if we are talking about proper rehabilitation process, cannot participate in recreational or religious activities, he will not be able to go out. So considering all these things, these problems or issues, we have to plan a rehabilitation program. Right. So not only these impairments, activity limitation, and participation restrictions, there are other factors also contribute to this rehabilitation process. Environmental factors and the personal factors. There are so many things. Right. So stroke rehabilitation is the restoring the normal physiology and anatomy, improving the activities to optimum level, or making the person independent, and achieving the social participation, or trying to reintegrate the patient in the community and the society. So after doing the initial screening and assessment, the rehabilitation team in place comprised of various professionals, and including all these people, of course, the patient, the family, and the caregiver. Very important. And all decision making, these three people should be involved. In any decision making, these three people are very important. It is not only the top people who take decisions. Aim is to prevent. So these are few practical aspects that I would like to talk, considering the time factor. I will not go into detail of the stroke management in detail, but I will talk about few aspects. How to prevent skin breakdown of pressure ulcers, prevent contractures. So these are the factors that will contribute to skin breakdown: hemiparesis, sensory changes, lateral, altered level of consciousness, impaired circulation, old age, urinary and fecal incontinence. So these are the factors that will promote skin breakdown. So regular skin inspection, minimizing or eliminating friction, maintain the adequate nutrition and hydration. So these are the things that you should be doing with your patient in the ward. And you educate the nurses, the medical officers, and all the others to pay attention to these things regularly in the ward. who are the patients at higher risk of developing skin breakdown? Dependence in mobility, diabetes, peripheral vascular disease, urinary incontinence, body mass index. So if the skin breakdown happens, generally it happens very early in the course of the disease, not later on. They will develop early in the course of the disease. So the correct position is to prevent all these complications, especially the joint contractures, the shoulder, elbow, and the knee and the ankle. The shoulder will be like this. To prevent that, you must position the patient in the extended, abducted, and like this. So these are the two ways where you can keep the patient. So when the affected side downwards, lying on the affected side again, extended arm at the shoulder and also at the elbow. And the leg also, what happened to the leg? It is hyperextended at the knee and hyperextension at the ankle. And to prevent these two. And if you are keeping the patient lying on the bed, make sure that the ankle is 90 degrees, put a weight or something, that don't keep the leg like this. That will end up in tight Achilles tendon tightness. It will be very difficult to rehabilitate later on. Right. Now, these are a few points I would like you to carry from now. All eligible patients with stroke should receive institutional rehabilitation. All. Rehabilitation starts very early in the acute phase itself. Comprehensive screening and assessment is important in planning the rehabilitation program. Very good history in various aspects. Prevention of stroke-related complication, skin breakdown and contact. You have to be mindful about these possible complications and prevent them. Appropriate preparatory rehabilitation facility includes good disease summary and subsequent follow-up plan. Thank you. So I invite all of you to come to this beautiful rehabilitation facility we have in Teaching Hospital Karapitiya, Melbourne. This is my staff with some awards that they have won for their services. Thank you. Yeah. Always.
Thank you very much, sir, for the informative lecture on stroke rehabilitation. We have 10 minutes left for the question and answer time. We can take few from the audience. Let me see whether there are any questions in the chat box.
Yes, what about you? You can ask questions now. Don't wait till the chat box opens. Start your chat box now. Wrong time.
Yes, please come up with some questions from our registrars, stroke management.
Question from Karun. If you mentioned there are some exclusion criteria. If there is a stroke, either hemorrhagic or ischemic, and the patient is having difficulty in communication, is that fair to exclude that kind of person from?
No, we will not. We will not send these patients. Ideally, what is important to know is that patient can be rehabilitated, and there is no question about that. The outcome will not be good as anybody else, but still you have to do something about this patient. So that patient will not be totally excluded, but still you can do positioning and these things to prevent certain these things. These patients will not stay in the rehabilitation unit for a longer period.
Yeah, and at this moment, is there a kind of a intermediate place that these guys can?
No.
Okay.
I have a question for Dr. Sena Ratna. For the clot retrieval, for the acute ischemic stroke, is there any difference for the anterior circulation clot thrombosis and the posterior circulation thrombosis for the time with regard to the time period?
Yes, I think there's a difference. And this thrombectomy, there are a couple of risk score systems they use, diffuse criteria and some other criteria. And depending on those, there's a difference definitely for the anterior circulation and the posterior circulation. For the anterior circulation, I know it has to be started within 6 hours. The posterior circulation, I think, I'm not too sure. Can Namit add something?
Yeah, actually, all the guidelines still they recommend for the anterior circulation. For the posterior circulation, simply there's no consensus. So that has not come to the stage for the guidelines. They only recommend for the large vessel occlusion in anterior circulation, that means intercarotid and M1, possibly M2. Posterior, the thing is, we don't have much data.
Right.
So, and it's time taking is 6 hours. Probably based on the dawn and diffuse 3 criteria. If you have the perfusion imaging, then probably we might extend that up to 24 hours.
Right. Okay.
But that's provided that you have the perfusion and diffusion imaging.
Right. Okay. Is it happening in Sri Lanka? Clot retrieval?
No, not in my knowledge. In private sector, probably there's one place doing it. NHS, there had been a plan few years back, but into my knowledge, still it's not kind of a functioning.
Right.
Retrieval, don't they do it anyway? From back when they do for sure. Prasad used to do that.
Yeah, they try to start it, but probably due to some logistic reasons and all that, they couldn't kind of continue it from the clock. Not sure about the current situation.
Can I ask a question from Nishant, please? About this neurosurgery, Nishant. When you let's say it's an internal deep bleeding clot. Now when you go in, you need to sort of go into the brain and take it out, is it?
It's a good question. I mean, it sounds funny to me, but it's a good question. You need to go into the brain for sure. There are different techniques. They're talking about endoscopic removal. They're talking about there are different needles. You can aspirate. Aspiration of a clot with a transparent sheet. It's a fantastic question, to be honest. What we do is do a craniotomy or a craniectomy, and then we need to do what is called a corticotomy. Corticotomy is you have to open the cortex. That is why deep-seated ICHs, intraparenchymal hemorrhages, do not benefit from surgery. We have to, by the time we go to the clot, we have damaged probably on your assessment about 1.5 million neurons. Good neurons. So good neurons, because we are making a corticotomy, we are disconnecting some of the connections. We have fascicles we are disconnecting, white fiber connections we are disconnecting. So there are modern, if you get the cross connections, we are disconnecting so many white fibers from by the time we get into the ICH. And we go and say, wow, we found the ICH, suck out the ICH, right? That is why they are saying it is controversial, right? So if you retract, if you have a brainstem clot, how are you going to get to the brainstem? You're going to go to the cerebellum, go through the cerebellar peduncles. That is devastation. By the time you come to the ICH, you cause a lot of damage. Therefore, there are certain techniques, that's why I said EVD is a very good way of removing it. If it's in the ventricle, you can put a Jamshidi needle, a small needle, or something like a small cannula and aspirate it, blow aspiration. But if large clots cannot be aspirated like that, we have no choice but to make a formal corticotomy, because stroke is better than death. Function is the last point. So So you prevent death, you prevent death, then you prevent disability, then you prevent dysfunction. So that's a kind of a philosophy that we go by. Thanks for the question.
Thank you.
Right. In the absence of any more question, I would like to conclude this session now in the interest of time. It was a very interesting, interactive, and fruitful session on stroke care. I would like to thank all of the resource persons once more for their invaluable contribution. I hope that our effort will help to update your knowledge on stroke care and that our patients will benefit as a result. I would like to cordially invite our Joint Secretary, Dr. Bhagya PSCD, to hand over the letters of appreciation to the resource persons. First, Dr. Ganaka Sena. I invite Dr. Ganaka Sena Ratna, our first speaker. Next, Dr. Damit Lienage, consultant neurologist. Next, resource person, Dr. Nishanta Gunasekara, consultant neurosurgeon. Next, our sir, Dr. Kalum Deshapriya. Thank you very much and have a nice.
We can't forget our moderator, Dr. Marshad Soisa.
Thank you.